love to introduce Dr. Eric Herman. Dr. Herman started working with the piezo wave, I think it's been almost 4 years now, over 3 years.
Yeah.
And then he recently, super excitedly, opened his own practice, Kinetic Specialty Veterinarians, and he's from Florida. I consider it South Florida, but I guess it's middle of Florida. So our plan, as usual, is he's going to give us a little information and chat about how he's been using the piezo wave post-stifle surgery and just post-stifle injury, and so a little bit about bone healing, because wow, I've gotten a lot of bone healing questions in the last couple of months. But we are also afterwards hoping to have some interactive discussion. And even if there is a question, or something, you have a question as he's talking, jump up and down, raise your hand, unmute yourself, talk. We do really want this to be interactive. We need to learn. My goal for doing these things on a monthly basis is that we need to learn from each other, and the use of our piezo shockwave is continuously evolving. I also strongly feel that there is no right or wrong way to use it, that we all use it differently, and take what you like, and I hope it helps you in the future. So turn it over to Dr. Herman.
Thank you so much, Cindy. And I appreciate all y'all for coming and joining this at the end of a long day. I know all of you have been working really hard throughout the day, so it means a lot that you're willing to come at night as well and hang out for this. So as Cindy said, I'm a genetic veterinary specialist. We recently opened our hospital here just outside of Orlando in Claremont. And our whole hospital is geared towards getting patients back up on their feet as fast as possible. Just quickly about me, I don't have any conflicts of interest here, unless Cindy wants to pay me, and then I will change that. So, but otherwise, we'll start off with shockwave effects on tissues. So shockwave benefits, the main part that I'm going to focus on is within the stifle is the bone healing, that it can improve osteotomy healing, can improve non-union delayed union healing, which I do have some cases that have been sent to me for fractures, especially in toy breed dogs for non-unions and delayed unions that we've gotten to heal with piezo wave as well. Also can help with osteonecrosis. I haven't had personally the right case for osteonecrosis. So like some of these Yorkies with moral head and neck osteonecrosis, the ones that get sent to me are typically quite advanced and starting to fracture. So I'm not seeing those early on cases, but if I get some of those, my plan is to be offering this first and then kind of going from there. And then the interesting aspect is the improving of osteomyelitis, because specifically one of the contraindications I was originally taught was for osteomyelitis as a major contraindication. But there is some information that is potentially showing that it can be useful for osteomyelitis. And then for the cartilage and chondrocytes, since we're primarily dealing with the stifle in this talk, you can have decreased cartilage destruction, which is part of why I really like early surgical and early rehab intervention in these stifle cases to try to maximize the long-term function of these joints and really minimize the long-term progression of osteoarthritis. And then they're seeing the most benefit typically about 3 to 4 weeks after treatment. And then the interesting aspect is that direct high energy shockwave may actually cause cartilage damage. So if you're really cranking this up higher than what people are advising, then you do have the possibility of causing some damage with that, although it's kind of unusual for people to go way higher because patients don't typically tolerate that. And then the analgesic effects, you can get a decrease in the pain for about 3 or 4 days after the treatment. due to direct nociceptor effects. And then on tendons and ligaments, fortunately, we have all of these in the stifle. Low energy shockwave can improve the repair. So for tendons and ligaments, the low energy shockwave is going to improve tendon repair. And then for soft tissues, it can improve neovascularization, which is part of where some people talk about it potentially having an inflammatory effect, but really it's bringing in new blood flow to the area, which is actually going to be long-term acting as an anti-inflammatory to help repair those tissues. And then it can also stimulate reepithelialization. So in a lot of my cases, they're post-op. So if they're post-op, then you can deal with the incisions as well. Okay, so for those of you that have the piezo wave in the manual for it, this chart should look familiar for you. So you can go through a very wide range of energy that you can put into these tissues. And that's one of the things I like about it is the versatility of it, as well as being ultra focused with the different pads that you can add onto it. But most of what I'm going to be talking about is going to be at setting level 9, which is at the 0.15 millijoules per millimeter squared. So some of the topics that we're going to be talking about are really at the joint capsule insertions and origins on both the medial and the lateral aspect. So this picture I think is important to know kind of where these are attaching, and at the very end I'll have what our protocol is. But essentially what we'll do is have the 5 millimeter pad centered almost, it depends on the size of the dog. So say you have like a pity sized dog, that pad is going to be almost the width from the fibula to the patella. And so I'll have like my thumb and my middle finger on those two landmarks, and then I put the pad in between the two, and that way I'm centered, and then I'm kind of rocking that probe back and forth over that, and that's kind of getting the origin of the medial and the lateral side, and then I'll do that both medially and laterally. And then on the distal aspect, similarly, for the lateral aspect, I use the 20 millimeter pad, and then I'm feeling the fibular head and the patellar ligament insertion onto the proximal tibial tuberosity. So I'll put my fingers there and have the probe centered between the two and rocking back and forth. So if an osteotomy was performed, then that's going to be hitting that osteotomy for almost all of the types of osteotomies that exist. But we'll talk about that too. But basically, that's also going to help with that joint capsule at the origin insertion there. And then medially, if you have a plate there, you want to skip over the plate. You don't want to be going right over the plate, partially due to vibrations, which some of the vibration concerns have to some degree been alleviated with the advent of locking plates. But back when everybody was using dynamic compression plates, then the vibrations could cause screws to back out of these plates. Not only that, it's reflecting your sound waves back out at you, so it's not getting to the osteotomy. So you may say you're doing 1,000 pulses. If you're doing 500 of those over the plate, you're really only giving 500 to the osteotomy itself, because anything that's hitting the plate is reflecting out. The concern of the screw loosening, I wouldn't be too concerned about screw loosening anymore with the advent of locking plates, but it's still not smart to go over that. And then if you didn't do an osteotomy, then you have the insertion of the joint capsule there immediately. And so you still have that aspect where you're trying to improve all the origin insertion of joint capsule so that you improve the range of motion, because they have shown in humans and in dogs that the range of motion is directly tied to weight bearing as well. So if you can improve range of motion according to the goniometry measurements, then you're going to improve how these animals are using their legs. Okay, so here's a wide variety of stifle surgeries that you may encounter. And excuse me, I think for those of you that are not doing the surgeries in your hospital, it's really important for you to get the x-rays. And I actually tell my staff that for all of our cases, they better be looking at the x-rays as well for every case, because sometimes depending upon that dog's anatomy, I slightly shift how I have the plate oriented and things. And so it's really important that you guys know where these osteotomies are if you're doing an osteotomy. So in the top left, you have the tibial tuberosity advancement, or TTA. Sometimes you might be seeing these cases where you're like, what's going on? There's no cage in this case. That's probably because they used a bioabsorbable cage, if that's the case. So don't fret, that's normal as well. But in these cases, you're trying to go right over where the osteotomy is, and you don't want to hit right at the cage as well. So a lot of these, you're going to be going, when you go to the lateral aspect, you're going to be hovering more cranially when you go with your pulses. So you want to follow down that vertical cut for a TTA, as opposed to like right next to it, you have to the right there, you have a CBLO, or a Cora-based leveling osteotomy. So ultimately, that's leveling out the plateau, similar to what a TPLO does, or a cranial closing wedge. But that is a little bit more distal for the cranial aspect than what a TPLO is. And you also then have that headless compression screw. So you want to avoid these things. So by seeing what the x-ray looks like, that's going to guide you as to where you utilize your probe. And then in the bottom left, we have a TPLO there. And then on the just to the right of that TPLO is an AP view of a TPLO. So if you can see between the proximal 3 screws and the distal 3 screws, there's a really thin line there. My mouse is not showing up to be able to show you that, but there's a really thin line there of where the osteotomy is. And then just to the right of that is a TPLO with a distal femoral ostectomy for a dog that had combined patella luxation and cranial cruciate ligament repair. So in those distal femoral ostectomies, you're taking out a lateral wedge and closing that down, but the plate is going to be lateral. So in this case, I kind of go slightly above where I'm trying to go for the joint capsule insertion. And so I will still do the joint capsule insertion, but then when I go just above that, that's where I'm going to be hitting that osteotomy. And I'll treat that osteotomy site the same way that I do a TPLO site. But it's important to have those x-rays so that you can guide where does your probe need to aim. So on one like this, where I only have a lateral plate, and then I'll center on the bone, and then I'll slightly cheat just a little bit caudal. And I'm like in equine x-rays, they taught us to really be good about naming them from like, this is a caudal to cranial projection, or sometimes you slightly oblique it and you go through the whole long name. So basically, I'm starting lateral and I slide the pad just caudal to where the plate would be, and then I'm angling it. So I'm going to be going from caudal lateral, shooting towards cranial medial with about 1,000 pulses there. And then I feel the plate again and I rock it cranially. And then I'm shooting from cranial lateral to caudal medial with that. And so you're trying to get kind of bio-oblique pulses through the osteotomy lines. But this is basically just important to show you, look at what procedure was actually done, and then where did that surgeon place those implants, so that then when you're going through and providing the extra therapy to make the surgery look good and heal well, then the shock waves need to be guided appropriately to get the most effect out of it. Okay, what's the literature say about this? And these are only geared towards the stifle. I didn't get into everything else. So Frederick et al. From Vet Surge 2020. A lot of people are using Nocita now. I use it for almost all my orthopedic cases, unless there's a contraindication, which is hardly any. So the interesting aspect is that laser has been shown to disrupt the liposomes and minimize the effectiveness of Nocita. So I wait 3 days at least to start laser therapy. I usually do a pre-op laser therapy, but shockwave has no effect on the liposomes for the bupivacaine at the currently recommended therapeutic levels. However, if you're really going above what is currently recommended, it will disrupt those liposomes and you have more release of the bupivacaine early. So therefore, you're not really getting the long-term effects of Nocita for those 3 days like you wanted. But if you do it at the therapeutic levels, you should be good.
Dr. Eric,
Yeah.
What are you considering a therapeutic level?
Almost all of these papers are saying that the therapeutic level is 0.15 millijoules per millimeter squared is what all of these stifle cases were done at. So that's what I would say is the therapeutic level. And that's what they were saying as well.
I was just wondering, so at that level, you're not seeing the in Nocita, you're not seeing the breakdown of the liposomes?
That's exactly right. It's when they went above that, they were seeing more of it. And at like the 0.39, they really saw release. But not at the 0.15. So then Barnes et al. Looked at shockwave in improving short-term limb use after TPLO. Let's see. I've got that paper up. 1 second, I'll tell you the doses. So they were going down at the 0.22, 0.29, and 0.39 millijoules per millimeter square. And that was because of reports going from 0.18 to 0.29. So as you go up into the 0.29 and the 0.39, and that's going to increase the release of it. But when you're down at the bottom of that, then you're not seeing release of the bupivacaine from the liposomes. So you should be good for that.
Perfect. Thank you.
You're welcome. And then, so Barnes looked at in 2019, she did extracorporeal shockwave therapy improving short-term limb use after TPLO. So they were doing 1,000 pulses of the 0.15, which on the piezo wave is setting 9 for the intensity. They were doing immediately post-op and then 2 weeks later at the joint capsule origin insertion, essentially. So that's the proximal medial, distal medial, proximal lateral, and proximal medial. They found an increase in peak vertical force with shockwave over 8 weeks post-op. And they also found that the weight bearing increased faster for the shockwave cases for TPLO. Although in that study, they did not find that the osteotomy healed faster with shockwave in that study. And then Barnes in 2015 looked at TTAs, and so they looked at TTAs that they just did the advancement with no cancellous bone graft and no shockwave. That was a control group. Then they did some that were just cancellous bone grafting, and then some that were just shockwave, and some that were cancellous bone graft and shockwave. And that the only group that was significantly different was cancellous bone graft and shockwave. If you look at the rest of them, the cancellous bone graft by itself or the shockwave by itself, those two did not have any difference between control, but the two combined did. So they didn't find any other differences though throughout that. But if you look at 8 weeks out, no difference between any group, but at 4 weeks out, the graft and the shockwave did show faster healing processes there. And then Kiev's VCOT 2015, same thing for TPLO. So she was specifically looking at TPLO cases. So they did 1,000 total pulses at the 0.15, and they were doing immediate post-op and 2 weeks post-op. They were specifically pointing out that they avoided the plate. They're the only ones really in these studies that made it a point to say, we very much avoided this. Everybody else just kind of talked about their other aspects of the shockwave protocol, but they didn't say specifically they were avoiding the plate. So she did 500 shocks caudomedial with the 5 millimeter trode, and then 500 shocks applied to the craniolateral aspect with the 20 millimeter trode. And that's because of the cranial tibial muscle there, so you have to have a higher offset. And she found that there was more advanced bone healing with a shockwave at the 8-week post-op. And then post-TPLO, a common finding is to have patellar ligament desmitis, which there was a recent paper that showed that 92% of 8-week post-op TPLOs have evidence of patellar ligament thickening. Now, granted, the majority of those were not clinical. But it's found on x-rays frequently in 92% of the cases. And so Gallagher back in 2012 looked at the effect of shockwave on patellar ligament desmitis after TPLO. They were doing 600 pulses at the 0.15 with 5 millimeter trode at 4, 6, and 8 weeks post-op over the patellar ligament. And they found that those cases that got shockwave had decreased patellar ligament thickness. And then they also found later on that the shockwave decreased radiographic signs of patellar ligament desmitis. No difference though in the ultrasound scores. So they didn't just look at the thickness on x-rays, they also looked at it on ultrasound. On ultrasound, they didn't find any difference in the scores, but on x-ray, they did see decrease in thickness. Okay, so what do? So we kind of go through immediately post-op, we will wrap the stifle with saran wrap, and that way the incision is protected, and make sure that there's no air or anything between the saran wrap, and we put pretty snug to make sure of that. Then we put the ultrasound gel right over that area. The main reason that we do that is kind of twofold. We don't want to increase the risk of infection by having ultrasound gel that isn't sterile getting into our incision. And then also that we don't want any possible contamination, even though we're cleaning the probe and everything, we don't want to potentially contaminate from patient to patient when you have all that swelling that's kind of oozing immediately post-op and things. So we wrap it with saran wrap, put the gel on, and then we go through 1,000 shocks or 2,000 total shocks. That's going to be at the proximal medial. So like I talked about before, basically feeling between the fibula and patella medially, and the same thing laterally with the 5 millimeter pad. When I say 5 millimeter pad, that's typically what I use, but like next week I have a 205-pound English Mastiff that I'm doing. There's a good chance that this is not going to be a 5 millimeter pad for that dog. So it's using your judgment to think about that tissue thickness. But the main thing that I've taught our staff to do is be thinking about to get down to where that joint capsule is originating or inserting, how much tissue are you going through? Because that's kind of where your focal is supposed to be right there in my mind. So but the vast majority of our patients is the 5 mm pad. So I do 1,000 medially, 1,000 laterally at the proximal aspect, and then we'll do 1,000 shocks at the craniomedial distal plate. So for the TPLO, right, you can feel the tuberosity, and then you should be able to feel where that bone plate is, and you're going to sit the point of your pad basically right there, and then I'll normally aim the probe basically right at the fibular head is where you're shooting for that. So that way you're kind of getting down and maybe just slightly distal to the fibular head is where you're shooting. So if you're doing that, you're going to be going right across where that osteotomy is, the vast majority of TPLOs. But having those x-rays can help you with your landmarks for how to do that. And then, so you'll do 1,000 shocks there, and then you'll switch out the head to the thickness of the craniotibial muscle, which is typically for the average medium-sized dog about a 20 mm pad. And you're going to do 1,000 shocks. So in this one, I'll put my finger between the fibular head and the tibial tuberosity, and then basically you're going to have the pad sitting between those two landmarks, and you're going to be rocking back and forth with that. You're going to do another 1,000 shocks there. So at this point in time, we're up to 4,000 shocks. And then lastly, we'll do, I do 800 shocks over the patella ligament, and I span the whole ligament. So part of why I upped that, even though the protocol from that patellar desmitis paper is 600, that 600 is for patellar desmitis, which is almost always down at the insertion of the patella ligament onto the tuberosity. And so I upped that by a couple hundred shocks, keeping it at the same thickness off and the same energy. But then I kind of run the whole probe up over that whole ligament there. And then I come back down from the base of the patella down to the insertion of that ligament. And then lastly, we have questions.
When we eventually we might have a video for those of us that need very visual, technician-oriented description.
Yes.
But I think what we really have to focus on is that this machine is specific enough that we have to aim it at the exact structure we're looking for, right? And
Yeah.
not just be a blind shoot, for sure.
That since we laser all of our stuff too, for different times, like, so we don't laser post-op, immediate post-op, we wait after 3 days. A lot of the staff that we hire is used to laser from other practices, but they're not used to shockwave. So that is a big learning curve of making sure that they understand that this isn't a shotgun, this is a sniper rifle. So we have to be much more precise with sighting this in of where we want that energy to be going.
Yep, for sure. Does anybody else have any specific questions, ideas, thoughts?
So Dr. Eric, 9 to me is in my practice, 9 has been an unobtainable number because my patients have been so sensitive. I've always lived in a much lower range and felt like I was getting good results. Are you seeing sensitivity at that level? What are your methods that you're using to help manage that? If you've got a dog that I mean, I'm assuming that. Well, I guess the other thing is, are they awake? The next part of that question is, are they awake post-op, or are they coming out of anesthesia when you're treating them?
Yeah, no, that's a very good point. So our most efficient time for this is that immediate post-op one because they're still gorked coming out of anesthesia. So those I don't ramp up at all and get them acclimated to it because they're not objecting to it. But then for their follow-up times, I'm not sedating them. I don't know the last case that I had to give anything really, but I don't like to do NSAIDs after 2 weeks post-op for any osteotomies because of the aspects of delayed bone healing anytime after 2 weeks, basically. But I'll tell them to keep some of the extra gabapentin on hand, and usually at least 2 hours before the appointment, then I'll have them give gabapentin as well. And I don't do the plums 3 to 5 mgs per kg gabapentin. I typically do 5 to 10 rounding up on my gabapentin dosages. So I think that a lot of those dogs tolerate that even at the like weekly doses of it. So usually week 1 is they're pretty good because they're still on NSAIDs. Week 2, usually they're still on NSAIDs and gabapentin, so they aren't as objectionable to it. But even in those cases, I usually start out around 5, depending on the case, and we actually make notes of where those patients might give some reaction. But we get up to 9 pretty quick, and there's some cases like I was saying for Jenny's dog, her dog lets us go straight to 9 and doesn't care, but she's a pity that like aims to please. So she won't object no matter what you do to her. But other cases, you're right, they get sensitive. So I usually start at 5 and ramp up from there and see when they start to react. But it's unusual if I go to where I can't get to 9. I find that I can get to 9, but sometimes it's a titration between, I usually start at a frequency of 8, and some dogs don't like the frequency, but they don't mind me getting up to the 9. So I'll titrate it kind of going up on intensity and down on frequency sometimes. So I might even get down to like 4 for a frequency, but I can get up to 9. And that 9 is really what I'm wanting. It just means that for that case, it takes me a little bit longer because of the frequency.
Okay. Did
Does that
Cindy?
answer that?
It does. Thank you. I feel like when I was talking to one of the other reps, Jody, or maybe you told me this, Cindy, that is it the 7, 8, and 9 frequency range where we see the most effect as well. Was there something based on that, or am I wrong on that?
So there is an old lithotripsy paper that the equine world will bring back into light, where they were saying 6, so 360 pulses per minute was ideal, but it was based on lithotripsy. So what we for frequency, we always recommend starting between 6 and 8 because that seems to be a middle ground. But the medical team in Germany is still insisting that there's no biologic change whether you go at 2 or the new machine goes to 12. So the hertz and the frequency doesn't have a biologic change. I do agree with Dr. Herman, when you use it on yourself and you find a specific reactive tissue and you play with going up and down, it feels different. I don't understand why.
No.
So
The cartilage damage study did not look at frequency. It looked at the intensity.
Yeah.
So the total energy that was going into those cartilage cells, but they didn't make any mention of the frequency having any cause to tissue damage.
yeah.
Cool. Okay. Well, thank you for that clarification. That's helpful as I'm thinking about treating some patients.
We set up this protocol quite a long time ago with the purpose of getting as close to what the literature does. Now, I know that there are a few bone healing case studies out there that people are in the process of writing up that are at less energy. We don't really know the lowest energy it takes for bone healing because that maybe they treat it weekly for 6 weeks and they still are showing good healing at week 8, even in a non-healing fracture. So the literature is telling us to go to 0.15, but nobody's gone down. Have you ever seen anybody gone down and not see any bone? And the dosing is complicated. There's no exact dosing. but clearly
It's-
0.15 is safe. Like it's enough to heal and it's not going to do any damage.
Yeah, I would say that's the important part is that we know that at that point we're abiding by the first sentence of our oath, right? We're not doing any harm. And we know that. And we have a fair amount of evidence that shows that we're probably doing a lot of good for it. If you look at the human studies and the veterinary studies on non-healing fractures, then I think that that's pretty ironclad at the 0.15, that that's a good setting for it. But looking at what energy might be acceptable, like one of the cases that I have done presentations on in the past is a little 3-pound Pomeranian with an RU fracture that came to me that was over 16 weeks old. So that case had been splinted. There was tons of osteoresorption there, and that was a challenging case. But then we plated it and we bone grafted it, and it was delaying, and so then we got the shockwave in. That was actually the case that I was begging Cindy to get the shockwave to our hospital sooner rather than later so I could shockwave that case. And so we started shockwaving it, and we finally got everything to heal for that case. But that case, that bone was a toothpick. I mean, I was using a 1.3 millimeter plate, and it looks gigantic on that bone. So if we're looking at these energy levels, that energy level for that dog is the same published for like you and I, for our radius in ulna. So, I mean, our radius in ulna is considerably larger than that little palm, but the energy levels are the same for what's published.
You know,
Yeah. You had mentioned, so this came up on one of the blogs or one of the boards. They were talking about inflammation from extracorporeal shockwave. And then one of the members came back and said exactly what you had mentioned in a slide, that it's increased blood flow that we're seeing. And so it's not really causing inflammation. Can you guys talk a bit more about its mechanicotransduction, Cindy? Did I say that right?
mechanotransduction, the story of my life.
Right, because I still think a lot of people just think we're slamming the tissue.
So the question at hand, and I actually just got a very interesting paper that makes some big implications on this. But the question at hand is, when we turn on mechanotransduction, we know from some of our anecdotal work that especially soft tissue, we don't have to use a ton of energy. And we also know that in rehab, on a weekly basis, we're trying not to make our dogs super sore because we want them happy and to come running back to us. So when we use those lower energies, which I would call lower energy 0.15 or 0.1 and below, we're getting good healing and we're not creating tissue inflammation, and we're not worried about NSAIDs. Now, why is that? That for me is that the biochemical pathway is mechanotransduction and moving tissue and secondary messengers. That is a pathway that is separate than the inflammatory pathway. Now, this recent paper that I haven't had time to really dig into is looking at, I think it's a 2022 paper, and it's in humans looking at autoimmune diseases in shockwave. And they made implications that they were seeing on low energy shockwave no pro-inflammatory markers and only the anti-inflammatory markers. Again, indicating that or implying that we aren't creating this huge tissue inflammation response that we used to. We also know when you measure the inflammatory markers post shockwave, when you pull the sample is a big deal, right? Like, did you pull it immediately or did you wait an hour? So I don't think there's any exact answer, but in the rehab community with soft tissue, we are leaning towards seeing lower and lower doses and getting great results and not making dogs sore. And, you know, mechanotransduction is all secondary messengers through a very complex pathway, but it's not the inflammatory pathway. So, that's kind of where there's no proven exact literature on it. And for me right now, in rehab, there's so much there's not exact literature on that. I'm okay with that. And I know that I've seen great results. Does that make sense to you, Paul?
It does. So you mentioned something that piqued my interest. So for the immune mediated arthropathy, I can't say that word tonight.
I can't
For
ever say it.
arthropathies, so shockwave would be an appropriate thing for those dogs
So
to
we
help
don't know.
decrease the inflammatory response.
We don't know. We don't know if we're gonna stimulate an autoimmune response. However, with low energy, most of the time, I have not seen it. I've seen one case on a polyarthritis that actually stimulated pain, a lot of pain, and one treatment where we said that's it.
Yeah.
It's not the treatment for that dog. But if it's a milder case, that particular case had so many it was so much bony proliferation around the joint that I couldn't even get into the joint line. So I think it was just too much. But on a lesser level immune mediated case, I'm okay to try at low energy because, and watch the dog.
Yeah.
The fact of the matter that I always warn people with immune systems is no matter what you treat with a shock wave, no matter how low or high your energy is, you are still creating an amount of physical stress on the biologic system. So that's the caveat. It is a biological physical stress. And will it flick that switch to, immune?
Yes.
We don't know. Exactly. So there's no correct answer, but this was a human paper studying it, and they saw with low energy shockwave very good results with elderly humans with an immune mediated arthritic disease.
Some of the other things that we'll do with being able to do things a little bit more comfortably for them for shockwave and some of the other modalities that we're doing is we also have the companion compression icing system. So usually after we do the shockwave, while we're kind of going over how the dog was doing for the rehab, then we're doing the companion compression ice system afterwards. So an order of how I normally do it on the recheck, so not the immediate post-op because of I don't do laser immediate post-op. I actually do it pre-op. And so post-op though, for the 1 week on for our protocol, we usually do the laser first and then shockwave second. And then as we're going over things with the owners, then do the icing system.
Okay. So you said that's 2 weeks, 2 weeks and 4 weeks post-op. You're doing that one?
At a minimum, if the owners are willing to come back weekly for the first 4 weeks, that's actually my preference.
Okay.
I've seen a little bit. This part is definitely anecdotally, but those cases that come back weekly for the first 4 weeks have by the 4 week mark almost are normal on their goniometry.
Well, that's fantastic. And then, so what's your amount of time? So you've got laser, and then you're doing shockwave, and then you're doing ice compression. Are you doing that over 45 minutes or an hour?
It's about 30. When it's a unilateral, it's like 30 minutes or so.
Okay.
And that's having everything sitting right there for that patient, like ready to rock.
Right.
And having the team that knows what's up with it. Like that's when we're teaching people, then yeah, it's easily 45 minutes. But when they've got their A game on, then it's 30 minutes is really what it should be.
Okay. And then my next question, of course, is going to be the one probably everybody's thinking. What do you charge? Do you charge them by time, or you charge them by modality?
So it's 180, and in this aspect, we actually schedule a total of 60 minutes with the client for all of this. But this includes the three things that I just talked about, but it can also include like the massage for a while, it and balance balls. So it can include anything up to 4 of our modalities. So we have basically like a pick list, and so this would be our level 2 treatment. Our level 1 treatment is a single modality thing. And then once you get into level 2, that's any of 2 to 4 modalities, but it's 60 minutes total. And that's $180. And then we have everything lined out there. So if you can do 2 to 4 modalities within that 60 minutes, then you can pick from that list and you fall into that. Otherwise, you bump into a level 3.
Okay. Thank you. That's really helpful. I mean, I know Cindy gets these questions all the time about what we should charge for
Yeah.
shockwave and how everybody's handling it. And certainly we have people, I've talked to lots of people that charge by the modality. And then there are people like me that just charge for my time, and whichever modalities I think are the best is what I pick, and in that time period, and just charge for that time. So I appreciate your input on that. What are you guys charging for a TPLO?
Uh, so we do TPLO scope for everything, and this is we actually include all of this with it. No, like not the follow up, but
Yeah.
so for the anesthesia TPLO with scope, simony lavage to minimize biofilm formation, Ioban everything, Nocida, femoral sciatic nerve block. I do polyglycan intraarticularly,
Nice.
along with dexmedetomidine intraarticularly, and then intradermal quill suture, which is also more expensive than regular suture. So I do all of that, and then immediately when they're waking up, cold compression and shockwave. All of that is for an average size dog is like 5K.
I think as people like to have it as the package, because when you sit there and you say, oh, I charge this for this and this for my scope and this for my Nocida,
Yeah.
and it just can be, as a pet owner customer, and that I feel it's overwhelming. It can be overwhelming.
Yeah, for sure. And the way I look at, I mean, we're roughly like $1,000 cheaper than everybody else around, and that's including general practices that do this. And even out the door when I was doing mobile, most of the practices that I was doing mobile at to a client they were hovering around 6 or 65 out the door, because like I charged them my fee for the mobile, and then they would up it for like all the anesthesia and stuff and hospitalization. So the clients that are coming to us now that I did their other leg on mobile, they're actually getting it for cheaper. Um, so they've been happy so far, but it gives them more money as well to put towards doing rehab. So, so I think that is an important thing to us, because we've invested a significant amount of dollars towards rehab, and we really believe that rehab makes surgeries look better. And also all those cases clearly that surgery is not an option. Can't be more minimally invasive than not making an incision. So those cases that don't need surgery, then we need to make sure that our rehab team is really set up to succeed. And so I think some of that is feeding them heavy with surgery cases, and then vice versa. Then the rehab team makes our surgeries look really good. So it's a good dynamic to have.
And it's a little bit of can be a unique dynamic nowadays, not everywhere, but there are still the no, I'll just do surgery and it's done, so.
Yeah.
Hey, Dr.
But,
Herman, can you touch on about how, like, what percentage of your cases are coming for post-op rehab?
I think it's the local cases we've been doing pretty well. I would say, and by local, I mean like within an hour of the hospital. I think that we're doing pretty well. I would say probably probably over 50% of those. And then ones that are over an hour away, I would say we're hovering around like maybe like 10-15%.
Yeah.
But some of those cases that don't come back to us that are over an hour away, they're actually going back to their general practice because the general practice does like laser therapy, and so they have these post-op laser packages, and so they're getting those there, but and I do explain that they're not getting the shockwave aspect,
Sure.
but or like the cold compression and things like that. And then I usually wait until 4 weeks out to start underwater treadmill.
Mhm.
So then like there's like 2 general practices around here that have option for underwater treadmill, but that's definitely the minority.
Sure,
So
sure. Are you seeing these cases that are following up with you on a weekly basis, starting at that 1 week post-op? Are you seeing less frequency of your patellar desmitis and like your iliopsoas tendinopathies?
I hardly ever see iliopsoas
Okay.
tendinopathy for TPLOs and like really stifle cases in general, to be honest. But as far as the patellar desmitis, yes, the ones that come back for that full 4 week package where they're doing weekly, I can't think of the last one I saw it in, to be honest. And then even the ones that are getting it every other week, so like immediate post-op and then 2 weeks and 4 weeks, I hardly see it in those either.
Mm-hmm.
But an interesting aspect on this, and this is one of the guys that I really look up to, Massimo Pezzoni from Italy. He's a surgeon over there, and he's really good at angular limb deformities and goniometry of all the joints, but thinking through the whole kinematics of how that leg is working. And I remember probably 7 years ago now, I was showing him some post-op TPLOs, and I was like, why am I getting patellar desmitis? And
Mm-hmm.
he measured out my osteotomy, and he's like, you're not centered. Somehow your measurements are wrong. And I was like, okay, so help me out here. So with the advent of VPOP for orthopedic planning software, it's like when I was taught TPLOs, I was taught you measure out the TPA and then you go to the chart and you're like, an 18 blade kind of fits for this dog. Yeah, let's do that. And then you just walk up with your needle up the medial collateral and you drop into the joint, and that's where you're supposed to be, right at your intercondylar eminence. Well, when they have a massive medial buttress, that is not where the eminence is. And with VPOP, you can be really precise of where your D1, D2 measurements are of your tuberosity. And so in surgery, I measure out exactly where my blade's going to go based off all those measurements. And the post-ops I've found look just like what the VPOP plans are, but it's because of taking that extra time to measure everything out very thoroughly. And I look at where I'm at in surgery for my measurements in relationship to that medial collateral ligament, and I point that out to my staff. I'm like, look at where this measurement is dropping this needle in. Here's where the collateral ligament. Sometimes it's 3 millimeters over.
Mm-hmm.
And I'm like, this is where I was taught to put this needle in and center my osteotomy. But if I would have done that, I would have been wrong. And so it's because of that medial buttress that pushes that ligament off to the side a little bit. And so I think that's a big portion of it, because just getting a really good osteotomy in the proper location,
Mm.
I really think that in and of itself plummeted my patellar desmitis cases.
Sure. Yeah, makes sense. Thank you.
Yeah. Best thing I would say though, with as a closing thing, is really develop that relationship with whoever is doing the surgeon if you're doing post-op cases. So that way you can get the x-rays and you can be really targeted with what treatments you're doing.
Great. Yep. Working as a team, not against a team. I thank you so much for your time, Dr. Herman. I thank everybody for joining us. And as normal, we will post this on our website. It takes almost a week, depending on how busy my helpers are, but it will be on the website, and I hope we all learned something. I know I did. Thank you very much, everybody. Have a great evening.
Thank you all.
Thanks, Eric.
Thank you.